The focused physical examination is a rapid assessment, and you should adhere to the concept of the golden hour. Perform your vital signs, respiratory rate, pulse, blood pressure, pupils, and skin signs. Perform all needed interventions, CPR, oxygen therapy, bleeding control, bandaging, or sling/splinting. You should make a transport decision and transport either code 1, 2, or 3. Remember, it is always important to make a radio call to the hospital. If the patient is not experiencing a life-threatening emergency, then you have time for a detailed physical examination. A useful acronym during the detailed physical examination is DCAP BTLS. Break down the detailed physical examinations in regions of the body, starting at the head, moving to the neck region, then the chest and the abdomen and so forth. Let's watch Mr. McMahon as he performs a detailed physical examination.
Usually I say, I'm going to examine you, let me know if it hurts, and I want to start with the person's head. And so I check the scalp, and I check for DCAP BTLS. Just remember that the DCAP BTLS is you're looking for wounds and injuries. So, for an example, the D could be any of the deformities, the C. So just think of the DCAP BTLS as types of injuries, and you won't go wrong. So I'm looking for like a deformity. I'm looking for bruises, contusions. I'm looking for swelling. Any of those things, maybe burns, things like that. So as I check the scalp, then I check the side, then I check the forehead, then I check the pupils. And with the pupils, we want to see if they're pearl, if they're equal and they respond to light. So we would take a little light and shine it in and have them maybe look at my fingers and then shine it over here to see if there's a response. Then we'd put the light down. We'd then check the nose. We'd check it here again for any of the deformities, fractures, bleeding, swelling, things like that, tenderness. Then we would check, really the zygomatic arches, the maxilla, the mandible. We would be looking at the nose and the mouth and the ears for blood or clear fluid. We would look at the back of the ears for battle signs, which is a basal skull fracture. Then we would look inside the mouth and we'd look for hydration and any wounds inside there. And that's pretty much, the head is finished, except for the very back. Then we'd go to the neck. And the neck would go through the DCAP BTLS. We would look for tracheal deviation, which means there's probably like a chest injury. We would look for JVD, which is maybe a chest/heart injury. We would look for the stoma. We would look for retractions. We would look for the medic alert. So those are very important things to be looking for right at the neck. So we could also palpate these areas. And as far as the deviation, if we did see that, would probably go right into what's going on with the chest because there's something really wrong there. That would be an intervention that would work right away. So then from the neck, we would go down to the chest. And I would probably ask him to take a deep breath, and I'd push in the center, take another one to see if there's any injury. I would then take my stethoscope, lift up the shirt, and I'd listen for lung sounds. I would listen at the top lobe, the middle, the lower lobe, top lobe, middle, lower lobe, and check for DCAP BTLS. And in pushing here, you're also pushing in the back. So if there's an injury to the back, they'd go out. And you'd say, where does that hurt? My back. Then we go down to the abdomen. And the abdomen, we would want to check the upper left, lower left cord, upper right, lower right. And we're looking here again for DCAP BTLS, any types of wounds. In the female, would be concerned maybe about the possibility of pregnancy. So we might ask some questions about maybe the last time they had a menstrual cycle. Then we get into the pelvic and the hips and the groin injury, plus the bladder. I would put my hand on the person's hip and rock across the bladder. If there was something wrong with the bladder, he would probably moan. I would check the top of, the iliac crest, and that's for the pelvis. This is for the hips. There's no injury. I would then look at the groin for any incontinence. I would look for incontinence of urine and feces, and that, of course, part of that is your smell type of assessment. In the male, also a priapism. I would look for that, which means there's probably a head/spine type of injury. So after we finish that, then I'd check on my side, the thigh, and I'd push a little bit here. I'd check the knee. He's ticklish. I'd check the lower leg, and then I'd check the ankle, and then I'd ask him what toe am I starting to touch? Can he push against my hand? Can he pull up? And so that's your CSM, checking for a pulse. Same on this side, push on the thigh, the knee, the lower leg, the ankle. What toe am I squeezing? Can you push on my hand? Can you pull up? And I could check for circulation. I could check for them both at the same time. And so that's pretty much, the legs. Then I'd come up to the top part, and I'd check the person's scapula, walk down, the clavicle, check the shoulder, check his arm underneath his armpit, check the elbow, the forearm, the wrist, and can you squeeze my hands? Good. What finger am I setting to touch? And I would check capillary refill. I'd check the scapular, the shoulder, walk down the clavicle, check, the arm, the elbow, check the forearm, the wrist, squeeze my finger, capillary refill, yes, movement. You could do that by holding your hands up both at the same time and have them squeeze to see if they're equal. Then with my partner and with the collar on, I want to roll them over, and I grab them at the hip and shoulder and would roll them over as a unit. And at this point, I can really get a good view of the back of the scalp, the neck, all the way down the back to include both sides. I could have an option of listening to lung sounds, checking the buttocks, checking all the back part of the legs, putting a backboard, and then rolling them as a unit with my partner, 1, 2, 3, would roll them back in the backboard and then secure them. And that's the end of your assessment.
While performing a detailed physical examination, break it down into parts. For example, the head. The head is not just the head, it's all of the parts that make up the head. Check the scalp, the face, the eyes, the ears, the nose, the mouth, and the jaw. Just like doing your assessments, the best way of remembering everything that you have to do is to simply break it down into its parts and take it step by step. Let's now listen to Mr. McMahon about the ongoing assessment and the trip to the hospital.
So, the next part of your assessment is the ongoing assessment, and that's the last part. What that assessment is basically you put them on the backboard, get them on the gurney, get them in the ambulance, and you do your assessment in the ambulance. And of course you'd want to repeat your assessment to, number one, see if you maybe missed something. You want to repeat your vital signs, because if his blood pressure and pulse was a certain thing and now it's changed, you might get like a key that he has maybe like a bleed inside. So you want to maybe speed up, turn on the red light and siren. And then you want to repeat everything, and then you want to start like the documents and give you a radio report. And after the radio report, you arrive at the hospital, give your report there, and you turn the patient over to the emergency department staff. So that's your assessment.
Following the detailed examination, and after you have loaded your patient into the ambulance, it is required that you continue assessing the condition of your patient. These are called the ongoing assessments. The ongoing assessments repeat the initial assessment and the focused physical examination. Check for changes in level of consciousness, mental status, skin signs, or the necessities for ABCs. You should repeat vital signs. You should look for additional complaints or injuries. You should continually review your interventions. Make a complete and concise radio report that includes your medic number, your estimated time of arrival, the code you're traveling, the age and gender of your patient, and your patient's chief complaint. Remember, monitoring your patient for change is a critical part of patient care, and the report you give to the incoming hospital will greatly determine the type of care the patient will receive.
And that's your assessment. So, you got to practice this.